Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about strains, all bunch of them, the hamstring, adductor, the hip flexor strain. We'll throw that in, maybe even calf strain as well. Are they really strains or are we missing the boat here? But before we get into it, Brandon, how's it going?
Going well, Jer. Early morning show that we're doing today. I have my coffee in hand, no boozing.
No boozing up
But
today.
still excited for this episode. This is a good one. We've had a lot of side conversations on this. Just on our own, and then in courses that we teach and mentoring residents and fellows. So figured we'd bring this one to the platform here, to the podcast.
Yeah, I think it's something that a lot of people try and use what is said by evidence, and maybe not get the results that they want, or they get the reoccurring strains and they start shooting themselves in the foot because it's like, well, evidence suggests this. Why is this not working? Why does this keep coming back? And that's when you need to really start to reflect and think back. Maybe something else is going on.
Yeah, and I think this kind of echoes some of our other podcasts and talks that we've had of umbrella diagnoses such as impingement or anterior knee pain, or Achilles tendonitis, tendinopathy, things like that. That oftentimes get these or bursitis. To get these labels, and we're treating them inefficiently because we're thinking it's one thing when it's really another. And I know a lot of our talks have gone, back to the spine and even neurodynamics. And I think that really holds true, especially when we look at hamstring and adductor strains specifically, because, people will point to that and they have a mechanism of maybe running or cutting, decelerating. So yeah, it looks like it should be a strain, but their healing time is way too long. And if you look at some articles, they're looking at hamstring strains should take 40, 50, 60 days to recover, and it's like, well, should a soft tissue injury really take that long? So that's that brings us to our topic, guys.
Yeah, and I think what you brought up too is running and cutting, and we automatically assume that's a soft tissue injury or maybe ligamentous and that sort of stuff. And it's easy to think, oh, it has to be that because they're in the sport and they cut or they slow down. But think about that, if you're, a couple 100-pound individuals, such and so forth, and you stop on a dime or do anything like that, though there's more trauma to just the soft tissue. If it was like abrupt or anything like that, it's not just the hamstring or the adductors. There's other things that could have been involved there. So that was something that took a little time for me to think of, like, oh, well, other things are getting involved. Like, think of it like a concussion. Yes, they may have concussion, post-concussion stuff, and it's in the head or the brain, but there's enough trauma to impact also the neck. So thinking of it like that versus, just chalking up of, oh, I was running, I feel in the back of my thigh, it has to be a hamstring injury because it's tough to do a straight leg race. Well, what else could have been involved in that situation? I would say, I guess, kind of go over things. Would you agree with this, Brandon, that I guess overlying evidence for these strains, I think all of them for the most part, hamstring, adductor, even calf, it's mostly what evidence supports is eccentrics, is generally the theme is things changed. I know isometrics were to start off, and now recent systematic review suggested that they really don't have as much of an analgesic effect as we once thought to believe, but it was kind of eccentrics if they're really kind of tuned up, and then isometrics if they were to start off and then progress into eccentric loading, and then plyometrics and return to sport, I suppose. Would you say that's a general theme?
Yeah, I mean, one of the articles I really liked, especially kind of going through residency, was one by Mark Sherry and Brian Heidenstein. I probably butchered that last name, but that was made in, I believe, 2010 or 11. And, they talk same thing like you just said, like isometrics, and then building up to more eccentrics and like what are they called, Nordics, or your feet, doing a bridge, drawing your feet in and then drawing them back out.
Mhm.
Look at what's required from that. What areas are being stressed aside from the hamstring. The neurodynamics are being affected and the low back's being affected. I think that's where we
Mhm.
need to go. Just like we have IT band syndrome.
Mhm.
You're just treating a tight fascial band. How is that the driver or the cause of your pain? It's usually something else. Just because, like Jeremy said before, the treating, what have you said before? Treating the site is a liar or something like that, right?
Pain
Treating
is a liar.
pain is a
And then
liar.
um,
There's another one, treating the site. I don't know, I forget the name of that one, but it is wrong, is erroneous. I forget what you're saying. It's too early right now.
yeah.
But yeah, so there's that aspect, and I'll go right off to say right from the beginning, um, you know, if unless there's like a lot of blood pooling in the hamstring belly, that hematoma and things like that, chances are they really haven't strained or tore their hamstring. Um, Especially if you're treating them and they're really not progressing and things like that. I think a hamstring strain should clear up pretty early on. And if they keep getting repeaters, like you said, this is like the third time coming to somebody,
Mhm.
start looking somewhere else. I think that's the biggest thing that we've always uh, talked about, and it's something I do in my clinical evaluation. Is I ask the patient, have they been treated before, and if so, I ask where, just to get a general idea, because you kind of, every place up here kind of has their own little like model within the company,
Mhm.
that if you're around long enough, you just kind of get a general idea of what's going on. And then I ask them what worked, what didn't work. So if they point out, oh, we did STM, or they used a bar in my leg and we did some exercises and we did X, Y, and Z, and they're still hurt. Well, I know I'm probably not going to do what they did, or maybe do a lot less of it, because if it's already been done, why am I going to go do more instrument assisted soft tissue massage? My instrument soft tissue massage isn't going to be better than the next guy's. All right. It's a pretty, you know, low level intervention, right? Versus, can we do something more skilled, and can I hone in on my examination? And I think this really goes into, are you doing a differential? Are you doing a proper differential on a proper screen? And does that start? I mean, for me, if it's a lower extremity, I'm starting at the lumbar spine.
Mhm.
So clearing out the lumbar spine, making your list, and really becoming a type 2 reasoner. We've talked about this a lot. Uh, becoming a type 2 reasoner, and not just using a type 1 reasoning pattern, which is pattern recognition. Yeah, they have pain at their hamstring or adductor or said region, and it hurts, and maybe they have a mechanism that might be similar to it, but are you going through and crossing off or ruling in or out any other possible scenarios or diagnoses at play? I think that's where a lot of PTs go wrong. They don't take the time to actually differentiate, diagnose, and too many PTs are worried about, oh, how do you treat this diagnosis, instead of how do I treat said impairments,
Mhm.
or limitations that a person presents with. Right?
Mhm.
So we need to start moving away from a diagnosis. I think we start doing that, our outcomes across the board start getting better.
For everything. As we mentioned before, like, stop relying on scripts, even post ops, and that sort of stuff. I still run them through the exact same screening process. I even said, I was like, yeah, maybe not ACLs and that sort of stuff. It's pretty clear for that. Nope. Now I've gravitated where I've now run them through the same screening process, because they may be missing something, maybe missing something that can be impacting their knee, such and so forth. Um, as an individual who did suffer a true hamstring strain, this was a result of going to grad school for whatever 3 years, not really being as physically active, and then as soon as I graduated, went and played pickup soccer. I had true like pooling, and my back of my leg was bruised and everything like that. Yeah, that healed fairly spontaneously. Didn't really need to do much or anything like that. But I had similar issues and pains on my opposite side, years later. It would seem it was easy to assume that that was hamstring because they had some weakness in the hamstring and such and so forth, but I had no mechanism of injury on the right. And doing like hamstring strengthening would have really helped me out. Doing an examination, one of my therapists or student physical therapists looked at my back, and they found out that the corresponding side was painful, tender, stiff, had some positive neural dynamics and everything like that. So don't let like previous injuries impact what you're going to decide to do. I think you hit the nail on the head with saying like try and find that real cause of things, especially with these type of injuries. If it's a true soft tissue like what I had in my left hamstring, it doesn't bother your back. It's isolated to that soft tissue region. It's not going to, unless you're really walking with a sweet limp or something like that, like you blew that bad boy up, maybe it can start to bother your back after a period of time. And I would still think, instead of thinking that there's a compensation, I would think, oh, the back got involved in that injury as well from day one. But I think for soft tissue injuries, it's going to be pretty isolated. So a good question to ask is, do you feel anything elsewhere? And people are like, oh, my back's stiff and that sort of stuff. Feeling things down a little further into the calf. Well, that's not hamstring injury or anything like that. So, make sure you ask those type of questions. I think I always ask in my evaluations if you have, do you have pain or problems anywhere else, even if you feel like it's unrelated? And I think I've seen Ernie, who's working with a fellow where I used to work, Ernie Gamble. He took it one step further and made sure he like touched each zone, like any problems with shoulders, knee, elbows, hands, and hips, knees, back, such and so forth. And that lets a patient know that it's like you're looking for things beyond just their problem area. I think that's really, really important with these chronic strains and stuff. So make sure you do that. And just to kind of top off some things, and if you're really like purely the EBP, I guess that's now become a camp itself in the physical therapy realm. And I want you to challenge you guys in the thing of like, oh, well, I do eccentrics, they've gone better and such and so forth. Well, see how long it takes, if it's 60 days and that sort of stuff. Did your eccentric loading, was that really just natural course of time? Can we get people better faster? Can we, resolve their symptoms quicker? Versus, them being out, 2 months that's a whole season pretty much at this point, especially with these COVID shortened seasons. So I think a lot of the times where I thought I had previous success because those previous therapists that were working with some of my clients and that sort of stuff, and they're doing mostly stretching and soft tissue stuff and whatever it may be. And I was like, oh, I'm gonna add eccentric loading and get some benefit and that sort of stuff, but didn't get all the way there, or it was reoccurring, more often than not. It's probably just natural course of time that things calmed down a little bit on their own, but didn't really truly address the root cause of their symptoms. And that's why it came back. I've had my pesky hamstrings. I'm like, oh, it's just a pesky hamstring. Or no, it's probably me not treating the right area to begin with. So that's a bit of a rant.
Well, while you were talking, I was thinking of another stubborn one, like you talked about. You miss a whole season, or an athlete can miss a whole season. I see this a lot in professional sports, and granted, we don't know the true cause, and a lot of times they'll use one diagnosis just to cover up something for the media and public. But lat strains is a big one. That it's like, what's a mechanism for a lat strain, right? And why is it taking these players 2 months to come back from it? I don't see it being a true lat strain. That should clear up within a couple weeks. And if not, I guess we'll give some tidbits of, places to look for anybody who's out there working with the overhead athlete. A lot of these overhead athletes are also rotation. I'd look at their shoulder. Are we mobilizing their shoulder and not just doing rotator cuff massages? Or lat massages, and then looking at possibly neurodynamics or treating their low back and mid back. I mean, the lat spans, basically almost the whole spine.
Yeah.
But definitely looking at T-spine rotation and
Lumbar.
treating into T-spine rotation, looking
Mhm.
at lumbar, possibly hips, especially in a sport like baseball, which is so rotary. Swinging a bat requires your hips and low back and torso. And then if you're a pitcher, obviously that shoulder as well. Even I shouldn't even say pitcher because if you play the field, you're still throwing the
Yeah.
ball.
Outfields.
So you still need to look at that shoulder and even neck. So
Mhm.
you're really looking through that whole really top half, even the hips I'm looking at as well, hip motion to see if there's any limitations there. That should clear up a lot of stuff. And if you're doing your A stem or you're dry needling to the lat and that patient's not getting better, or they get better in the session, they come back and they're like, yeah, it came back. I challenge you too to start looking elsewhere, start expanding the way you treat.
Mhm. So I take it another step there is pec strains, right? And
I was
God,
thinking about that.
I was a pec soft tissue monster. Getting in there with I've elbowed people, all these sort of things. Think about all the things that refer to the pec. I mean, one, it's like, yes, in the throwing motion. So right there, we got neural dynamics, median nerve, maybe other nerves, ulnar nerve. Um, first, second rib refer down into there. Even the collarbone, I've had seen some issues with that, and that can impact the anterior chest, the neck, CT junction especially. So, really, really try and dive into that test retest. I think especially like, let's say for the pec strain, let's say I either do first rib or CT junction. All right, so they're tender here. They had the mechanism. They're diagnosed with that. Well, me manipulating their CT junction, wherever, shouldn't just make that that tenderness and the ability to stretch that strained muscle magically get much better. So yes, there's no physiological effects and that sort of stuff, and but I think if it's a true strain and mechanical to the tissues there, it's not going to have as much of an effect versus soft tissuing it for 10, 15, 20 minutes. So I think I think the main point what Brandon brought up is not unless you have true ecchymosis or maybe a classic pop, even if it's maybe especially grade 2s and 3s. Most of those true ones, they do report that they felt something pop and then followed up with some bruising.
Yeah.
um Even the grade 1s, I would say if it's a grade 1, they usually report something like that. Maybe it's not as profound, but if those things aren't adding up, if you're not listening, hearing those things, that's when I start to think maybe it was something else.
Yeah, to go back to your pec point, I mean, and we talked about clearing out the first rib and CT junction and things like that. I mean, look at what innervates the pec. I mean, it's that lower cervical nerve roots, right?
Mm.
It's your 6, 7, 8, and 1,
Mhm.
right? So why aren't we treating that area? We had a patient, one of my employees had a patient and they were complaining of kind of widespread pain through like their pec and to the sternal region. And, the guy had no cervical motion. And I had, made the comment, just start with the neck and see what happens. And that widespread pec pain kind of came very focal into that cord process. And, patient still was insisting on it's his pec. And we had our therapist educating us like, I haven't even touched your pec and your pain's getting better.
Mhm.
So it took a couple of visits. Our patient was getting our therapist was getting a little impatient. He's a newer grad, so he's like, well, should I be going anywhere else? I'm like, you got the results treating the neck, keep treating the neck.
Mhm.
Maybe go further, different segments.
Mhm.
Maybe look at the shoulder neurodynamic, but it's there. Um, so he decided to not and dance around and play with the scap and do some pec soft tissue to the pec, and no change was happening. I was like, okay, what does that tell you? You now need to go back.
Yeah.
But if you
Uh,
want to do some pec massage just for the patient because they swear it's the pec, and you do 5 minutes of that just to kind of appease them, then do that. But
yeah.
understand where you're getting your changes from, and if all else fails, go back to what was working.
Mm-hmm. And ideally, like really take the time. If you got something that's working and making progress, I understand it's obviously a process and that sort of stuff, and stick with it. A lot. I think, especially the motivated clinicians, students, we're always like, all right, I want them better yesterday. And especially if it's chronic issues and that sort of stuff, you're not going to cure them in one, but you can make a big impact. So don't like throw it out like, oh, it got me to this point, let's end it, let's find something else.
Yeah.
And then you try and find something else. One of the patients starts to think like, oh, maybe they don't really know what's going on. And then if you have to backtrack
Yeah.
and then go back to it, then it's just like, oh, did we waste some time and that sort of stuff. Not saying you shouldn't experiment. Always, look for the best of the best, increase by 5-10% improvement on each session, such and so forth. But sometimes we just gotta stick with it, and don't throw the baby out with the bathwater, as Brandon always says on the show. But yeah, there's some I think we're pretty good. I mean, Brandon, I don't know if you have you had any good case studies lately or anything like that besides this one that you just referenced?
Yeah, so that would be the one that was most recent. I've had a couple other adductor strains, and this is where it comes down to knowing some referral patterns, knowing, thinking outside the box, knowing somatic referral patterns, nerve referral patterns, even muscular referral patterns.
Mhm.
A lot of things in the QL or the hip flexor can actually refer pain all the way down into the lower leg.
Mhm.
So understanding that, like I've had somebody with lateral ankle pain, and this is back when I was able to dry needle. I dry needled their hip flexor and it recreated their ankle pain, and their ankle pain went away.
Mhm.
Now, is that because it's the hip flexor, or because there are nerve roots that innervate the hip flexor that can also go down, innervate lower leg as well? Possibly.
Mhm.
So, understanding things like that. I've had several adductor strains where I've mobilized the TL junction or upper lumbar, and it
Mhm.
refers, and they're like, that's my pain.
Yeah.
And that's usually found in my assessment, where we talk about we clear out the lumbar spine. It's not just doing your range of motion, it's doing your spring testing. And if it recreates pain, I don't even need to go any further. Like, I'm just going to stick with that. If that recreated your pain and you told me that, we've all said, listen to a patient long enough to tell you how to treat them.
Mhm.
If I'm mobilizing or spring testing the area, it recreates the pain, I'm just going to stay there.
Yeah.
And now I know it's the lumbar spine. Maybe I need to look at the hips and mobilize the hips, or do some neurodynamics for obturated nerve or something like that. But
Mhm.
the crux of it, great lumbar spine, I'm going to mobilize it and manipulate this sucker.
Yeah.
And a lot of times it happens within a session or two.
Yeah. And even if it's not so much, I think especially our younger students and clinicians, which are like so fixed on something objective needs to be found. And there's asymmetries in the human body, which I fully agree with and such stuff. But if you're on spring testing and it's like the left adductor strain, it's been bothering for a while, reoccurring, and you're doing your spring testing and everything that TL junction or maybe a little higher, a little bit lower is all painful on the left or stiff on the left. Yeah, you may not get a pure recreation of things. Sometimes it's not that easy. You get really good at your hands, understand your pressures, you're probably more likely to be able to do that. There's plenty of times where I have a student run through it and then I go in and all of a sudden they're like, I feel that in my hip.
Yeah.
I feel that in my groin. I'm like, all right, so work on those skills. But if you're finding some stuff in the back, it's stiff, it's painful, and the other side isn't, add that in, treat that right there and then see if it helps. So don't always chase the recreation of things. Sometimes, especially early on, it's not so easy to find, but you'll find little subtle things that can cue you into treating that area. And if it doesn't work, screw it. Go right back into the groin or adductors, whatever it may be. But don't blow it off or bypass it just because it's a diagnosis. We recently had a girl that got a hamstring injury, reoccurring. I was working with PTs and that sort of stuff. It was 2 sessions. The second session was, I would say, wasn't needed at all. I was actually surprised she came in. I was texting her mom. She just wanted to follow up and everything, but it was one session. We manipulated her back, did some mobilizations, and her hamstring pain was completely away. And we did nothing related to the hamstring.
Yeah.
So, and
And
she
those are the
was ready
ones
to be
where,
shut down. Huh?
sorry, I said, and those are the ones that you treat them and it's like you're half an hour into your session, you're like, yeah, I think we're done.
Yeah, that was
Right.
pretty much it. It was like my student Pat was with me and maybe Kayla too. And they're like, what else do we do? I'm like, is she pain free? She was like, yeah. I was like, okay, it's over. I don't know what else more to do. You don't need to go into the weeds of hamstring eccentrics or anything like that because she
Yeah.
just needed her back to be loosened up.
Yeah.
We referred her to a strength and conditioning person to keep doing things and have a well-rounded program, but does she need to spend 15-20 minutes just working her hamstrings? No. So sometimes that's it. We just need to what was it Jason Glassman, the TPI course? He's just like manual therapist or like bulldozers. So he's like, give them as much as they can to do on their own, like clients as a strength and conditioning person. And then every once in a while, if it's just not working, you bring in a manual therapist, medical professional, and they'll just bulldoze things and then they get right back into it. Especially for these chronic strains.
Yeah, if anything, I was going to say those 15-20 minutes can be used to mobilize their self mobilizations of the hip or low back or something in that region. And for all you sports therapists out there, sports, I put that in quotes, or aspiring sports therapists, not everything is movement modulation and having the perfect squat or perfect lunge. And while okay, they're pain free, but there's more to it, yes, to an extent. But a lot of times you get a pretty high level athlete, you're an athlete in general, like they're probably pretty conditioned already. You might have to tweak a couple things here and there and improve things, but you probably don't need to go and do as much as you think you need to. And as a sports therapist, there's definitely a inherent bias, and I think this comes from just the older mentality and generation, that okay, you need to be great soft tissue skills and exercise. Like it goes beyond that. And I think if you start expanding your realm into being able to truly differentially diagnose, improve your manual therapy skills, joint-based manual therapy skills, neurodynamic-based manual therapy skills and assessment, that's just going to carry over into your sports side as well. We've said this before, sports is a subcategory, subgroup underneath orthopedics. So you need to be good at your orthopedics first before you just jump into sports. And I think that's where, APTA has, or really our profession just has a horrible identity crisis. We don't know what the fuck we are. And, going into right away, just jumping into sports without having that true orthopedic knowledge, you miss a lot. And I've said this before on a podcast, and I'll reiterate it now because we're on strains and this tends to be a more athletic population. Working alongside therapists that have undergone training in a sports residency, a lot of those programs don't focus on the spine. And a lot of those programs will often have an OCS or a orthopedic residency and a sports residency. So the sport guys tend to not get access to the spine because it's not required or needed for sports. But the orthopedic guys do. So when it comes down to it, you guys end up being limited. Like I literally worked alongside, and he was a great therapist, great sports therapist, but we'd come to the spine. He's like, yeah, I don't know. And I was like, oh, have you looked at the spine? He's like, no, we were taught this. I'm like, well, examine the spine. And more often than not, a lot of stuff came from the spine. So, if one, I think sports programs should start including the spine more in the curriculum. And two, if you're a sports therapist and you're not looking at the spine as often as maybe you should, hopefully this podcast encouraged you to do so.
There's whole clinics with that kind of mentality. It's like, oh, we're a sports clinic, so we just see the peripheral joints.
Yeah.
Like, oh, well, does that mean you look at the spine? They're like, no, we look at the joint itself. I'm like,
look at the injury.
And we've mentioned it was a study from McKenzie, but it was looking at individuals with peripheral joint pain. It's like 300 people, and how many of those actually had a spinal source? It was like over 40%. In particular areas, the strain areas, is actually found more so in the belly areas, biceps, forearm, quad, thigh area, and calf region were more likely to be actually a spinal source than the actual joint area. So, don't ignore all the research for it. And test it out, challenge yourself. That's the biggest thing, is sometimes we, we're in our own biases and that sort of stuff, and we try and be open. That's why I like to take students from different schools and different thought processes, but challenge it. I think there was a good case studies, or I've heard a couple where the therapist did one thing one session, one thing the next session, one thing in the other session, and then self-compared. And that was cool enough that they wrote like a case study on it. Do that yourself, especially if you have people 3 times a week. I don't really see too much 3 times a week anymore. That's great, to play around with stuff. Do something on Monday, do something different on Wednesday, do something different on Friday. Be real good about, testing some measures, whether it's a pain, a patient specific functional scale, PSFS, or other test retest measures that we've discussed on the show. But yeah, really just challenge yourself, guys.
Yeah, and I'll go into your study that you said that comes from the spine. What's our definition of the spine? Do we include neurodynamics in it, or the spinal cord in it, or the nerve roots in it? Which I think we should. I don't think a lot of people do. So again, what's our definition of something, I think also goes into how we look and view things. So just food for thought for the audience there. And there wasn't just your study that you talked about, the McKenzie. There's a study by Lever. 80% of people with shoulder pain have neck pain as well. 60% with elbow pain have some type of neck pain or spinal source. And then I think wrist pain is about like 40%.
Yeah.
So you're still looking about, of the upper extremity, about 50% of your people have some type of spinal or cervical involvement.
Yeah. It's a big chunk. So definitely takes, at least warrants a time to at least assess it. So, and if you don't have a good assessment skills, that's when, take a, more specific course on like, cervical thoracic or lumbopelvic or thoracic itself. If those skills have kind of gotten a little bit rusty. But yeah, I think that's pretty good for today. Yep. Thanks for tuning in, and looking forward for this is right before the New Year's, so looking forward for our 2022 courses. And yeah, cheers everybody.
Cheers, guys.